Hey everyone, good afternoon. It's Susan Coffin. I'm here for Attitude Magazine for our weekly ADHD Experts webinar series. Thanks so much for joining us today. We have a great visiting expert today on a great topic. It's Dr. Thomas Brown on, is it really ADHD? How do I get the diagnosis right? We hear from so many readers who and listeners who have spent years not accurately diagnosed, being diagnosed for all sorts of other disorders. And I guess at the end of the day, there's no definitive test for ADHD. There's no lab test. There's no one brain scan. There's no genetic screening. So evaluating, diagnosing ADHD is not quick and it's not simple. Doctors who don't specialize in ADHD and all of its related conditions can go down all kinds of blind alleys. They oftentimes suggest depression, anxiety, or any number of other conditions before they arrive at the right diagnosis. To tell us how ADHD can and should be diagnosed, we're so pleased to welcome Dr. Brown today. He's going to be talking about topics such as which professionals are best suited to diagnose ADHD, the tools that should always be used in an evaluation, about the validity of brain imaging, computer tests, or other diagnostic lab tests in ADHD diagnosis, the role of rating scales, how they're useful and when they're most needed, questions patients should ask of a provider before they start a diagnostic process, why clinicians should always evaluate for co-occurring conditions, anxiety or ODD or other conditions that frequently overlap with ADHD, and the importance of using the new DSM-5 in an ADHD evaluation. Dr. Brown will explain what that means. So thank you so much, Dr. Brown, for joining us today. We're always so happy to have you.
Thanks, Susan. It's a delight to be back.
Thanks. And let me introduce Dr. Brown briefly. He is, for those of you who haven't had the privilege of hearing him speak before, he is a Yale-trained clinical psychologist who specializes in the assessment and treatment of ADHD and its related problems in children and adults. He has been associated with Yale University for more than 25 years and is just this month relocating to Manhattan Beach, California, lucky California, to open the Brown Clinic for Attention and Related Disorders. He has been for many years associated with Yale University and will henceforth be associated with the Keck School of Medicine at the University of Southern California. I cannot recommend his books highly enough. They are clear and extraordinarily lucid explanations of attention deficit disorder. And his newest book, called Outside the Box, Rethinking ADD, ADHD, A Practical Guide, was just published this month. You can reach him at brownadhdclinic.com. So thank you so much, Dr. Brown. We really are so grateful to have you. I'd like to thank the sponsor of today's webinar, NEBA Health, N-E-B-A Health. NEBA is the only FDA-cleared test that helps a clinician diagnose ADHD with accuracy nearing that of a team of doctors. NEBA helps clinicians catch cases that look like ADHD but are something else. So for more information about NEBA, go to nebahealth.com. Thank you to NEBA. A few housekeeping notes before we start. You are all muted. You may post your questions for Dr. Brown in the control panel of your screen. After his presentation, he'll respond to questions, so do put them in, your comments there. If you have any problems hearing us, what sometimes happens, it's certainly your internet line, and the best solution is to dial in via your phone line. You'll see a phone number in your control panel. After our sessions, you'll always find a replay of webinars at attitudemag.com/webinar. Note that that's a new URL. We have a new website, which we hope you'll visit. It used to be attitudemag.com/webinars. This is plural, but it's just one webinar now. And also within a week or two, we will normally have a podcast version available in the iTunes store. So if you like to listen in your car or whatever, you will find the audio there. We'd love to have comments, ratings, reviews of our podcasts and webinars, so please log on to iTunes and give us a rating or at the bottom of the webinar page on our website. So thank you all, and with that, let me turn it over to Dr. Brown.
Thanks, Susan. Let's begin, and greetings to all of you who are on this webinar. I'm delighted that you've tuned in. And today what I'd like to do is share with you some of my thoughts about what's involved in getting a good, adequate assessment for ADHD. And one of the things that comes up is the question of sort of when can you tell if somebody has ADHD? Incidentally, I tend to use the terms ADD and ADHD interchangeably as I talk. I'm not necessarily talking about subtypes with that. Just please take it as one stands for the other. But what you see on this slide is a mention of the fact that there are some cases of ADHD which are really noticeable even in the preschool years. Usually the kids that show up in my office at ages 3, 4, 5 are kids where the parents are having a lot of trouble in managing them for safety purposes, for one thing. You know, that these are the kids who you really got to hold their wrist anytime you take them outside the house or in a store, or they're just going to get loose and they're likely to run into a street or jump off of some place where they can't safely land, or stick a table knife that's going to miss into an electrical outlet. The other place where often these really young kids show up in need of help is that often for those who have it very early, often they have a lot of difficulty with sleep. And so many times you've got this kid up at 2 and 3 in the morning, waking up everybody else in the household, or just not able to settle into sleep. So there's some cases where mothers can tell you, this kid, I've had several kids, and this kid is really different. He's much more difficult to manage. He tends to be very restless and overreacts to things, and usually it's a big concern about safety. However, there are a lot of people who don't show, a lot of people with ADHD don't show it until much later. There are certainly some where you begin to see it when they get into elementary school and are having to deal with group activities, where you're expected to sit still in a classroom, where you're given tasks and expected that everybody would follow on the task, and so forth. But there are many kids who function quite well as long as they're in that period when you have one teacher most of the day who tends to provide a lot of the structure and the executive function guidance for the students. The thing which happens upon another sort of transition point where you'll see it more often is with a kid who may be functioning quite well in school, even honor student level in elementary school, but then as they get to middle elementary or junior high, when they start to have not just one primary teacher with them most of the day, but rather they get moved from one classroom to another, and now they've got to keep track of what materials to bring and which assignments are due when, in which place, and there's a reshuffling and different sets of expectations. At the beginning of middle school, and certainly as they move into high school, there are many who've done well up until that point, but they have a lot of difficulty because now they have to manage themselves. And ADHD is really about the brain's management system, the person's ability to organize and prioritize and get things started for themselves, the ability to keep one thing in mind while doing something else, the ability to persevere in tasks even when they're not super interesting. And so those things become much more noticeable, those who have problems with them, when they get into middle school or junior high or high school. However, you know, there's some families where the parents are providing such careful scaffolding to protect their kid with ADHD, to remind them that when they need to get to bed and helping them keep track of what assignments are due when, and assisting them in organizing themselves and insisting that they not be staying up all night playing video games, and that they need to stay in and get things done. And that there's some students where you don't see their difficulties in school until they move away from home. And then suddenly that scaffolding is removed, and you've got somebody who up until that point had not shown any evidence of ADHD because there was so much structure and support being provided for them. But when suddenly that gets taken away, as it is if you move away from home to go to school, to college, that's the time when you begin to see more difficulty. So these impairments of ADHD become noticeable at different points with different individuals. Now, before I go any further on talking about what's helpful for an ADHD diagnosis, I'd like to clarify some things that are not particularly helpful. One of them is brain imaging. If you follow the literature, that's in the medical literature, what you'll see is there's some really interesting work being done and valuable things that we're learning from brain scans, from MRI studies and PET studies and fMRI and DTI studies. However, contrary to what a few practitioners are doing, where they're asking people to pay a lot of money to come in and get their brain scan done, and then expect to be told that they'll know what kind of ADHD they have and what to do about it. People who really know about brain imaging and ADHD will tell you, as I'm telling you now, at this point in time, brain imaging is not a useful tool for diagnosis of any individual. We've got a lot of information about groups of people with ADHD and what we can learn about brain imaging and brain development and so forth, but we do not have the large number of normative pictures to have enough of a picture of what the wide range of normal looks like at various ages to be able to make a diagnosis on that. And also because ADHD is fundamentally a functional problem and a chemical problem in the brain, and it's not a structural problem. It's not something where, like a tumor, where it's in there and you can see it, or a broken bone where you can see it on imaging studies. All we can watch is process, and the process that we're looking at is connections and interactions between infinitesimal little cells connected with one another in the circuits, and it'll happen so fast you can't catch it in imaging in a way that's going to help you know what's going to happen the next minute. Number two, there are some people who are referred to get very expensive $2,000, $3,000, $4,000 packages of neuropsychological tests for ADHD diagnosis. And among specialists in this area, I can tell you that they are generally useless for making an adequate assessment of ADHD. The reason is that these are tests that are given in an office in a period of anywhere from 20 minutes for 1 to an hour or 2 hours, or a whole battery of 6 or 8 hours worth of various tests. But they don't tell you a damn thing about how the person's functioning day by day in everyday life. And that's where the troubles usually come up in ADHD. So that's not a good way to spend your money. Neuropsychological tests are very good if you're trying to evaluate brain damage after a traumatic brain injury, or if you're looking for stroke damage and so forth. They are not useful for being able to assess and treat ADHD. And then I've got the term EEG there. This is just one of several different electronic ways of measuring what's going on in the brain. And again, they can look impressive, just as the images that we get from brain imaging can look impressive. But these are pictures of how the brain is functioning in a very short period of time. And that does not tell us much about the longer term picture. There's some argument about this in the field, but most specialists recognize that these are not tools that are going to make a substantial difference in making a diagnosis. And if you go online, you'll see there are a wide variety of computerized tests of attention that people are selling to say, well, if you take this test, you'll be able to see if you can refrain from hitting this key when a particular target is shown on the computer screen very briefly, or if you can be sure to hit it quickly when the target is shown that you're supposed to hit, then you can compare that with other people and see to what extent that is or isn't similar to people with ADHD. Those things take quite a bit of time. They're basically boredom tests, and for the most part, they're not going to be able to tell us. They very rarely have false positives, but they often have false negatives. Often they will say there's no problem when in fact the person just happens to be very good at video games. Same thing is true of genetic testing. There's a lot being done now on mail in your saliva or your blood sample, and then we'll tell you about your genetics and whether you're vulnerable to particular disorders. We're still not at a point where we can do that because the genes involved in ADHD are not just 1 or 2 or 3 or 4 or 5 genes. It's a very large number of genes, each of which contributes. It's a highly genetic disorder. It runs in families. Out of every 4 people diagnosed with ADHD, one of them has a mom or dad who's got it, whether they know it or not, because in the old days they were never any good at diagnosing ADHD, and even today it gets missed a lot because of inadequate training for doing this kind of assessment. But the fact is, you can't say, does this person have or not have ADHD based on any genetic testing? It simply doesn't work. So those are some things that I would suggest you set aside and not plan to use if you're trying to get a question answered. Does the person have ADHD or do they not? All right, well then, who can diagnose it? Well, generally it's a good idea to get a medical professional to do it. And that might be a pediatrician, it might be a psychologist, it might be a psychiatrist, it might be a physician's assistant or an APRN. However, the fact that somebody has that training and that certification does not in itself mean that they are adequately trained and experienced in diagnosing ADHD and other things that go with it. The reason for that is quite simple. Most people going through these trainings in medical school and in nursing school and in PA school and even in psychiatric or psychological residencies do not get adequate training for recognizing and assessing ADHD. Many times the people who are doing it, the people in each one of those specialties who are really quite good at it, but most of them have had to go and take special training in order to be able to really learn how to do this right. And so that's why you see the big if they have the training and experience in diagnosing ADHD and related disorders. And it's worthwhile if you're planning to have it. You can certainly make a first stop if you've got a child and you're wondering about it at the pediatrician and ask, are you in, I assume you probably know about what ADHD is, but are you really up to date on it? And how much experience have you had with that? Do you do the assessments yourself, or do you usually refer to a psychologist or a psychiatrist who's had some experience in doing this that you found helpful? However, there are some pediatricians who are quite good at it, particularly more in the developmental behavioral pediatrics subspecialty. But there are also some good physician's assistants and APRNs who can do it. So the critical question is not simply sort of what's the label on their profession, but whether or not they have gotten enough specialized training and experience to do this task. Okay, so what happens when a person's getting a clinical diagnosis? Now, the abbreviation here, clinical HS, stands for clinical history. The place we usually begin in trying to understand does a person have ADHD is to talk with them, to have a conversation with the patient, unless they're very, very young kids, and even quite young kids can usually respond to some questions. In the case of younger children, it's very important for the parents to be interviewed in detail. With older kids, I'd still like to see, when I'm doing it, I'd still like to see the kid and parent together all the way through college, if that's possible. But the main question is sort of, what is it that makes, why have you come here today? What is it that makes you think you might have ADHD? And you want to listen to the clinician listens to the examples and that the person says, or they say, I have a hard time focusing. The next question is, when? How do you notice it? What are the areas in which you have that difficulty? Is it something that's happened for a long time, or is it something that that's just occurred recently? The reason for that question, of course, is a person might be acutely depressed because somebody's just died who's important to them, or they might have had a medical illness or something like that, which is bringing on this difficulty, or they may have had a concussion or some other head injury. So the question is, what are the presenting complaints? How long have they been an issue? And in what domains are they noticeable? For example, is it a student who's having trouble only in one particular class? Or is it something that seems to appear in a variety of other classes, or a bunch of different tasks they have to do? And so we want to get the story on how long has it been this way, and what are the areas in which you see it? And is it something that happens in more than one place? Is it something that is there trouble not only in school but also in getting homework done? Is it something that happens in a variety of domains? And so we want to get a picture of current functioning, how the person does in school, if there are students, or at work if they're employed. How good is their performance? Are they able pretty consistently to do what's expected of them, or are there a lot of days when they just can't quite get it together? I find it's always helpful to ask about the person's strengths too, because I like to know not just what are you having trouble with, but also what can you do well? For two reasons. One is that helps me make a better assessment, and the other thing is it doesn't bury the identified patient in just being embarrassed about all the problems that we're talking about. But ADD is not just about school or work problems. It also has to do with social relationships, getting along with family members and getting along with classmates. And one of the ways I get at some of those things is to ask, what do you do for fun? Is this a kid who actually interacts with other kids and gets along reasonably well with them most of the time? Sure, there may be difficulties with a sibling or something like that, or is this somebody who's often irritable or often is anxious and pulls back or wants to spend all the day in the room playing video games? Are they functioning well in sports? Is this somebody who is able to play their sport and keep their head in the game pretty well, or is it that they forget what the coach has said and that they aren't paying enough attention even when they're doing their sport? Is the kid playing in the outfield and watching the pigeons fly over at a time when the ball is coming out toward them? And I think it's also important, this is going on with other things that need to be talked about, I think, in the clinical interview. What's the current living situation? Who's in the family? Who lives with the patient? Is it one or both parents? Are there other family members, brothers, sisters, uncles, aunts, cousins, grandparents who are living with them? Is this a situation where the family's able to be pretty supportive, or is it one where the parents are having a lot of difficulty? They're chronically arguing a lot with each other. Is there a situation where somebody's got a drinking parent or a sibling has a drug or alcohol problem and they're often drunk or high, or do they have temper problems? What kind of stressors are there? Is the family stressed out a lot because they've just moved from one part of the country to another or from one street to another? Are there difficulties with somebody who's lost a job and their financial pressures? What are the supports? If the parents are not able to support, is there a grandparent or an uncle or an aunt or a teacher who's particularly helpful? Or is this a kid who's having a lot of difficulty and just doesn't get enough support? The next thing that I find helpful is, because ADHD is inherited, I usually say I'd like to take a few minutes now to ask about the family. You've already told me a little bit about who's in the family, the immediate family. But now let's think about the larger family, the extended family. Think for a minute, please, I'll say to the patients, think about anybody living or dead who's blood related to you. Parents, grandparents, uncles, aunts, cousins, brothers, sisters. Anybody living or dead who's blood related. Is there anybody among those people that you've heard about who's had a reputation for having a lot of difficulty with paying attention or with learning certain kinds of things, maybe good in reading, not so hot in math, or vice versa, or who just seemed like they're pretty smart, but they did a lot better once they got out of school than when they were in school? And then I'll report, because what I'm fishing for there is to see, is there a genetic pattern? Very often when I'm meeting with parents and kids, I'll be reading the list of symptoms with the kids and going over it, and then one or both parents are pointing at the other, saying, hey, this apple didn't fall very far from the tree. I went through very similar things as I was growing up. That's important information. But I also inquire in the same way about anybody in the family who's had a lot of trouble with their mood. So I get depressed a lot or wildly hyper. Anybody who's had a lot of trouble with anxiety, big time worriers or panic attacks. Anybody who's had a lot of difficulty with routines where they've got to do things a certain way, or has had a lot of trouble managing their temper. And anyone who's had a lot of trouble with drugs or alcohol. So you get some sense of what's in the gene pool that might possibly be related to the difficulties that this particular person has. Another area that's really important to inquire about is health. How's the person's health generally? And is this somebody who gets sick quite frequently? Do they have chronic problems with asthma or with digestive difficulties? Do they have are they taking any medicines? Sometimes they're coming in, they've already started taking some medicines for ADHD. Other times they may be on medicines for pain or for infections that they're being treated with. And it's important to know what the general health picture is, but also what medications they're taking, because particularly for adults, many of whom are taking a variety of medicines, you want to be sure that that's not something that's influencing the process. Are they taking any medicines that might possibly be contributing to the problem or might interact with ADHD impairment medications? And then there's a question about drugs that are not prescribed. With very young children, you don't usually have to worry about are they drinking a lot of alcohol or using street drugs. But with kids who are junior high or above, it's important to inquire about whether they're involved in drinking or using marijuana or any other street drugs in past or in the present. And usually when I'm dealing with young adolescents or young adults, I don't ask them in the presence of their parents the question about alcohol or drug use. What I'll do is ask the parents, do you have any reason to believe that your son or daughter is involved in drinking or drugging in a way that's messing them up? And then I'll watch the kid's eyes. And then what I'll say is, I'll talk with you about this a little bit later, because I want to see the kid separately from the parents. And usually I'll say to them, look, I'm not telling your parents what you tell me, but I do need a straight answer. Are you smoking weed? Are you, if so, how often, how much? And are you drinking, how much? Because sometimes parents are not fully aware of whether or not their kids are drinking or drugging, or they think they're doing a little bit and they're doing a lot, or sometimes it's the other way around. Another important area to be covered in an evaluation is sleep. So these abbreviations you see here refer to asking about different aspects of sleep. I usually ask, what time do you go to bed at night? On school nights, if it's a kid. And then a separate question, okay, if you get into bed at, you say 8:30, 9 o'clock, 10 o'clock, 11 o'clock, whatever time it is, if you then say, okay, I want to go to sleep now, how long does it take before you actually fall asleep? It's that latency issue of how long between, okay, I want to go to sleep, and the time you're actually asleep. And for many people with ADD, that takes a long time. And what they'll tell you is, I have a hard time shutting my head off. And so I stay up late reading or watching TV or surfing the net or whatever until I'm exhausted, and I fall asleep fine. But the problem then is it leaves me with kind of a short night, and it makes me tired the next day. IA stands for intermittent awakening. Is it somebody who's able to get to sleep all right, but they keep waking up during the night? DAW is the abbreviation for difficulty awakening. Many people with ADD, once they fall asleep, sleep like dead people, and they have a hard time resurrecting themselves in the morning unless somebody's really pressing them. EDS stands for excessive daytime sleepiness. There are many people with ADD who report that unless they're doing something that really interests them, that they often, if they sit still and aren't talking a lot, that they tend to get drowsy, their eyelids feel kind of heavy, and they're about to nod off. Then we also want to ask about, how's your appetite? Are you a big eater or not such a big eater? What's the pattern of your eating? How much do you weigh? How tall are you? And then think about that, particularly with young kids and adolescents, about how does that fit with other kids their age? Well, often I'll ask you, if we're lining up all the boys in your gym class or all the girls in your gym class, where would you be standing in the line if we went according to height? Has there been a big change in your height or weight or your growth over the course of the last year or two? And then on the final thing, there are previous evaluations. Sometimes people who are coming in to get evaluated have already been seen by school evaluators for educational testing or by a school psychologist who may have run an IQ test. Or there may have been some outside speech or language evaluations, or the kid may have been in 0 to birth to 3 programs early on. And getting information about that can give you some clues a little bit about what the difficulties are. So those are some of the things that I usually like to see covered and I think are important in getting a good clinical interview, clinical history of a person who may or may not have ADHD. How long does it take? Usually my evaluations take about 2 to 3 hours, depending on the situation, because it also includes explaining some things about how we understand ADHD these days. Many clinicians do not have the luxury of that much time. For example, many pediatricians have only about 15 minutes in which to do a one-patient interview. But the answer to that is either use a double interview or bring the person back 2 or 3 times. The point is you don't want to get an evaluation that says, why do you think you have ADD? Oh, because sometimes I have trouble focusing, and then let that be that. And on the sometimes things, let me make one point. I'm not going to talk about it in great detail, but I've seen thousands of children, teenagers, and adults with ADHD. And I can tell you every single one of them has a few domains of activity, some particular interests or activities in which they have no trouble exercising those same functions that they have a lot of trouble with in almost everything else they do. With their memory, with their organization, with their being able to get started on things, with their keeping up the effort. And if you ask them about it, you say, well, what is it? Well, how come you can pay attention so well and get so involved in doing your video games or in playing your music or in rebuilding car engines or doing your craft projects or playing your sport and be so focused and do so well at it, and then you get in class or you're trying to do your homework and you can't stay focused at all, or you keep forgetting the things you just read. Usually what you'll find is that people with ADHD, all of them, have a few activities in which they have no problem paying attention or utilizing these other abilities that we refer to as executive functions. In just those few activities, though, they have enormous difficulty exercising the same abilities in other situations. That's the nature of ADHD. It looks like a problem with willpower, but it's not. ADHD is a problem with the dynamics of the chemistry of the brain. And so it's important to appreciate what they can do well, but the fact that someone is able to focus well on a few specific activities without any difficulty does not mean that they do not have ADHD. Everybody I've ever seen who has ADHD has that ability. The problem is, how do they do across the board in the wide variety of tasks they need to do for daily life? Information from school is important. It's helpful. Students who are with one teacher most of the day, the comments from that teacher can be very helpful. And they can tell you a little bit about how the kid gets along with other kids, what subject areas they are able to work in comfortably, how they compare with other kids of the same age in each subject. And if you ask with interest and don't get too argumentative about it, those teachers can tell you a lot, much beyond what they put in the report cards. However, it's also important to recognize that when a kid is in junior high or in high school, where they have maybe 6 different teachers, 5 or 6 different teachers every day, and the teachers are seeing about 5 classes a day, each with 20 or 30 kids in them, the teacher reports there are going to be more limited. And there are many times when one teacher doesn't see a problem at all because that student has particularly interest in that subject or in that teaching style, even though some other teachers may see it a lot. It's useful to get that information, but it doesn't have quite the same depth of acquaintance with the kid that you're going to see with the teacher who's spending most of the day with them. Often there are some standardized test scores. One of the questions you want to ask about that is, did they have enough time to finish it? And did they leave a lot of things unanswered? Because many people, not everybody, but many people who have ADHD have a lot of trouble in taking tests. For example, that they often will read the test question, and then particularly if it's a block of narrative that you have to read, and then they've got to go back and read it again because it doesn't stick inside their head. And sometimes they got to go back and reread the same couple of paragraphs 2, 3, 4 times in order to really get it stuck in their head. And in those cases, it's very helpful to for those who have ADHD to get more adequate testing, and if in fact it shows up that there's a problem with this, to be able to get accommodations like extended time for testing. But it usually requires a battery of tests to be given. And then we also want to ask about homework. How does this kid do in terms of being able to keep track of what needs to be done and to set priorities in terms of focusing on what needs to be done now, and not to spend a lot of time working on something not due until much later and neglect the things that are due tomorrow. You know, and so usually when I'm doing an evaluation, I'll ask the kid, how much time do you spend on homework most nights? How long does it take you? And I know it's different from one day to the next, but on average, about how long does it take you? And they'll give me a number. And then I'll say, how much of that is actual productive time where you're really getting something done? And how much of it is just circling the airport where it's not productive, you're screwing around or trying to get organized and more spacing out? And then there's also the question about task completion, which I referred to earlier, the one on the bottom. It's, you know, are they able to complete tests in the standard time? Because if they are not, then that's an important thing to note in the evaluation, because they may need some more testing. Another thing which Susan alluded to in her opening comments is that often people with ADHD, kids or adults, have other things in the package. In fact, we know that if you're looking at adults with ADHD, we've got research evidence that shows us that an adult with ADHD has 6 times the likelihood of having at least one other specific problem with learning or emotion or behavior in addition to the ADD than anybody who does not have ADHD, 6 times the likelihood. And so it's important to look at what other things go on. Sometimes people are identified as having ADHD when they do have ADHD, but they've also got a substantial depression going on, and also very anxious, or they're also getting high 2 or 3 times every day and have a big time substance use disorder. So the person who's doing the evaluation needs to know how to look for other things, how to look for specific learning disorders. Somebody who may not be able to read very well compared to others of the same grade and age. Somebody who has way more trouble doing math calculations or even knowing how to set up a math problem. Or someone who has a lot of difficulty in being able to take their ideas and put them into sentences and paragraphs. Those are all difficulties. And so anxiety, depression, learning disorders, chronic sleep problems, difficulties with substance use disorders where they're drinking or drugging too much. Most common, of course, are alcohol and marijuana. Obsessive compulsive disorder where the person has to do things a certain way or they just don't feel right, even though that way may be very inefficient. Problems with mood, where they have mood outbursts, they flip out easily with mood. Or oppositional defiant disorder. These are the kids who live with their middle fingers up. But the point here is that it's important for the person doing the evaluation to be able to recognize these other difficulties. I've just described a number of them, mentioned a number of them here, and to be able to look at it and see, is it that this person is depressed and they have ADHD? Or is it that they have just depression and that's contributing to the ADHD symptoms? Or is it possible that that they have both? The problem, of course, is that many clinicians are much better trained for recognizing and diagnosing anxiety or depression. And many educators are better at diagnosing reading, math, or written expression learning disorders than they are at recognizing our current understanding of what ADHD is. So what's necessary for a valid diagnosis? Well, we've talked in some detail about the clinical interview of the clinician with the patient and some other people. It would be usually it's a parent, one or both parents. Sometimes it'll be other people who are in the family or who are particularly important. And then there's the normed rating scale. Norm simply means that this is a rating scale that has been tested with a large number of children of similar age, and a sample of some of whom have ADHD carefully diagnosed and some don't, so that you can get some sense of, okay, which problems here are just regular kid problems for kids this age, and which seem to really be a problem beyond that looks like it might be ADHD. And there are a number of different ones. There are the Conners scales. There's the BASC has norm rating scale data on it. The Brief has it. The Brown ADD scales have it. The Stiefel test has it. The Barkley test does. There are a number of these that are normed, where you can look at the scores, the rating scales, particularly using self-report and parent report and teacher report, and get some idea of how does the picture of this particular child at this particular age fit with what we know statistically about what's typical for others of the same age. The DSM-5 is the manual, the diagnostic manual from the American Psychiatric Association that lists the diagnostic criteria for each disorder, including ADHD. And it's important for any of these evaluations to go through each of the 18 criteria of symptoms and then the other diagnostic criteria for this to determine whether or not it really does meet the diagnostic criteria for ADHD. However, there are 9 inattention symptoms and there are 9 hyperactive impulsive symptoms, and one does not need to have all of those. For young kids under 17, they need 6 of one group or 6 in the other. And for people 16 and up, it's 5 of symptoms in one area and 5 in another. That's, there are some problems with the diagnostic criteria. There are a lot of things they don't include, but those are the ones that are currently agreed upon, and that needs to be part of the evaluation. You need to do the screening for the co-occurring disorders, the sort of thing we just talked about. There should be a physical exam. A physician, pediatrician for the young kids and an internist for the older people, should check to be sure there's not a medical problem here that's being overlooked, and also to see if they're in shape to be able to take medicines if they need it. And you need somebody who can make a comparison with others of the same age group, because many times, particularly young parents or parents who don't spend much time with other parents of kids of similar age, don't have a clear picture of when their kid is having considerable difficulty in certain functions relative to what most kids of the age can do. And then, of course, the task is putting the pieces together. But there are a couple of other things I'd like to emphasize now. And that is that the initial assessment, that's important to establish the diagnosis. And another important part of it that I don't have time to cover today is that the initial diagnosis should also be a time to educate the patient and family about what ADHD really is, because our ideas about ADHD have changed a lot over the last 10 years or so. As we've learned more about it, our research has been more helpful in identifying the various characteristics of ADHD at various ages. And to look at the comorbidities, the co-occurring disorders, and the course of treatment. That's all part of the initial assessment, but then that doesn't mean the whole job is done. There still needs to be ongoing assessment to monitor the effectiveness of the medication or whatever the treatment the person's getting, and to take a look at any side effects and to watch for emerging problems that may not have been obvious when you did the first evaluation. Here are some red flags. These are some things that you might want to think very carefully about if they come up. One is if you're seeing a physician or any other clinician who's writing a prescription for medicine for ADHD without doing an adequate evaluation, that's trouble. This is what I talk about as drive-through evaluations, the sort of thing where the patient comes in and sees the clinician, and there are just 2 or 3 questions asked, answered, and then the prescription's written. That's not providing enough help to the clinician to find out whether or not this is a reasonable assessment or a picture of what's going on. And it's also very likely to lead to a mistaken diagnosis. Failure to include information from the school. If the patient is a student, you want to be sure you've got that information from the school, because school studies are the job of the student, and we need to know how well that's functioning. Some people only focus on problems of the school and don't pay any attention to what's going on at home. It's important to look at both, because many times some of the difficulties that a kid is having may be reactive to difficulties in the family. If you're presenting your son or daughter for an evaluation and the clinician says, oh, don't worry about it, it's going to pass. Keep in mind, time goes on, and living with ADHD, which is not adequately recognized and treated, can be very problematic because it lets people go on believing that they are stupid or that they're lazy, and they could be blamed for that when in fact that may not be the case at all. If the person is not using any normed rating scale, that's a question, because you need something more than just the individual's judgment. If a person doesn't seem to think it's important to have follow-up, that's a problem, because there are many times when you can't see the whole picture clearly when you're there for that initial evaluation. And then there are some people who get too fundamentalistic about interpreting the diagnostic criteria. There's some times when a person may not have exactly all of the diagnostic criteria you'd expect as the threshold, but they've got a lot of trouble with some things. You want to look and see if there's something else going on, but one doesn't need to be too rigid about this. You need to use clinical judgment when you're using the diagnostic criteria. What you see here on this last slide is the web address for my clinic, where you can get more information about many of these things. And I have now published 5 books about ADHD, all of which are still available. The one in the upper left-hand corner called Outside the Box is the new one that just came out this past week. And if you want a lot more detail about evaluations and how our notion of ADHD has changed, you might want to take a look at that book. But let me stop now and ask Susan, do we have any questions that
Sure.
People would like to have answered?
Absolutely. Let me just ask the listeners, if you would, please post on your control panel what your specific diagnosis issue is. Is it for a child or an adult? Are you concerned about the interaction between depression or some other disorder? There have been people who mentioning OCD versus ADHD, depression,
Okay,
other
can
things.
you get a little closer to your microphone or jack up the volume a little?
Sorry.
I'm having some trouble hearing you.
Can you hear me now? Is that better?
It's not 100%, but it's better.
Okay. Let me just see if I can. Is that better?
I need a little more volume, please.
Okay. Can you hear me now?
Yeah,
Hello?
I'll listen harder. Go ahead.
Sorry. Okay. So let's see. There are lots and lots of excellent questions. A specific one, which I found interesting, is someone is asking about what are the key things to look at in distinguishing between depression and ADHD, specifically in adolescent girls.
Mm-hmm.
I know that comes up. I know we hear about that distinction a lot at Attitude with women who have not been diagnosed correctly with ADHD for a number of years. And what about depression versus ADHD? How should a clinician approach that?
Well, there are some cases where the difference between depression and ADHD is very easy to recognize, although it can be some of both and as well as an either or. And that is, if you've got somebody who has very significant and chronic problems with getting to sleep or with staying asleep, that's something to pay attention to. Or if you have a person who is having a lot of difficulty in being able, their eating has gone way to either extreme of not eating enough or eating all the time and not feeling satisfied. And or if they are having a lot of questions about whether they want to stay alive. Those are signs of major depression, and they need to be taken very seriously and evaluated carefully. And the person may or may not have ADHD with it, but those are things that you want to look into. There's safety issues involved here. But the other thing to keep in mind is that I often compare living with an ADHD which is not adequately treated as trying to run the Boston Marathon with a knapsack of bricks on your back. You can do it, but you got to work a lot harder than everybody else, and the results that you get for yourself aren't anywhere near what they would be for somebody with the same ability, the same effort, who just doesn't have to carry the bricks. If a person has ADHD which is untreated, it can be demoralizing.
So they could actually be depressed as a result
and
of.
They begin to get depressed, but then in that case, you want to, if you can rule out major depression, you may want to treat for the ADHD first if it looks like they meet those criteria, and see what you get, because often then there's a lot of improvement when they begin to feel more hopeful and less incompetent. And then if it looks like there still is a lot of difficulty with depression, then I might move in with an antidepressant. But many times in a situation like that, where it's primarily demoralization, just feeling so hopeless about oneself, often that it improves a lot once the ADHD improves.
That's interesting. Yeah. We've certainly heard that from many listeners.
I'm sorry, please repeat what you said. I'm still having trouble hearing you.
Sorry, I'm just confirming that we often hear similar situations to what you just described. Question about rating scales. Wondering whether you have a specific set of rating scales that you prefer for diagnosis?
Well, I'm a little biased because I've published my own rating scales, the Brown ADD rating scales, but I'm not certainly not going to claim that those are the only ones that are useful. The Conners scales have been used for a long time, quite successfully, and all of mine and all of Conners scales and Barkley scales are designed to be used with a wide range of age groups. And then the BASC is often used in schools, and there's a version of that that addresses ADHD symptoms. And also the BRIEF is another set that worked pretty well. So each one of those has its own strengths and difficulties. But the main thing is to get something that is normed so you can get a reasonable comparison between how this person's functioning and what's typical for the age. But the other thing that's important to keep in mind is you don't make a diagnosis on the basis of any one measure alone. I've had some people with heavy-duty ADHD where they come out with very low scores on rating scales because they're just minimizing their problems, because that's the way they see it. Even when they're trying to tell the truth, they minimize it. And then I've had others who have, but they actually do have ADHD. And then I've had other people where the scores are coming out very high because they're so harsh in criticizing themselves that they make it sound like they're having much more trouble than they really are, when in fact they may not have ADHD, but they may have another problem as well. So no one measure is sufficient to make the diagnosis. It's the combination of the clinical interview plus the rating scale data, plus what you get from the school, plus these other measures which I have referred to, that the combination is the job of the clinician then to integrate that information, what the patient himself or herself says, and what the parents have to say and what the teachers say, and put the pieces together.
Okay. An interesting comment from Celia, who asks if you could speak to the issue of hyperfocus as a symptom. She says that, I think this is very common, Celia, I'll just comment, that they never thought their child would be diagnosed with ADHD because he focused so well for so long when playing Legos or something like that.
Yeah. And
however, in junior high, you know, when executive function skills started becoming necessary.
Then it hit the fan.
Yeah. Right, right.
Right. Okay. Well, I think that's a very valuable thing to bring up again. That's the kind of thing I talk about this as the central mystery of ADHD, and that is, why is it that people who have ADHD, kids or adults, can focus very well on a few things that really interest them, but not well on most other things that they know are important? And it's exactly that. And it's a matter of when you're faced with something that's really interesting to you, not because somebody said you should be interested because it would improve your grades or your job review, or something that scares you because you're really afraid that something that you think of as very unpleasant is going to happen fast if you don't take care of this right here, right now. Under those two conditions, really liking it and really being interested in it, or being scared that it's going to cause trouble for you that you don't want to see happen, under those two conditions, it changes the chemistry of the brain instantly. And the problem is, it is not under voluntary control. And so you end up with people who have ADHD where people look at them and say, well, you can focus so well on this and this and this. Why can't you do the same thing on that and that and that? And the nature of it is they can't make it happen by their own determination.
Right. Okay. Yeah. Hyperfocus is just a very tricky one.
It's a way of saying, actually, hyperfocus, you know, I think it's a way of talking about how I can focus very well on some things, but not on others.
Not others.
But there's also another problem with it, and that is that sometimes with people with ADHD, they can't shift their focus when they need to. they'll get locked into one thing, and then it's like they can't shift gears. And that in itself is a problem, which is typically characteristic of ADHD, but you also see it with OCD, and you also see it with autism spectrum.
Okay. So speaking of autism spectrum, there are a number of questions, similar questions from 5 or 6 people about distinguishing between autism spectrum and ADHD. Specifically, how can a clinician distinguish between Asperger, mild Asperger's, and ADHD when the symptoms are so similar?
Well, there are some similarities in it, and the simple fact is that about half of the kids, at least half of the kids diagnosed with autism spectrum disorder or Asperger's, also have ADHD. You know,
Okay.
There was a long time when people were not recognizing that these things overlap, but they do. And the distinction has to do with a couple of different things. One is that the people with ADHD and autism spectrum disorders or Asperger's typically have a lot of difficulty in being able to manage social communications in terms of interacting with other people, particularly people their own age. They often misunderstand what's going on or misinterpret what's going on, and they often have trouble expressing themselves in ways that will fit with how other people are understanding things. It's that they can't use their understanding of what people are, how people are likely to react to a situation to guide their behavior. And there are some rating scales that can be used with that. The social responsiveness scale is one that's often helpful, and that's good across ages. And then there's autism diagnostic forms as well. But that's an area of important overlap.
Right.
And it's certainly true that a lot of people with ADHD without any autism spectrum characteristics have some difficulties in getting along with other people. They're too impulsive, or they're too loud, or too bossy, or too intrusive sometimes. But the patterns that are involved in really an autism spectrum diagnosis, and I would include Asperger's, even though I think they made a mistake when they tried to put it back in under autism spectrum. Those are things that you need to be able to tease it out, and it takes somebody who knows something about autism spectrum and about ADHD to do that right.
Okay, right. A similar set of questions, interestingly, about language processing. Specifically, someone says, does ADHD and language processing disorder oftentimes coexist?
Often they do coexist, and yet they're not the same thing. Mm-hmm. And the same thing is true of ADHD and dyslexia or reading disorder, or ADHD and disorder of written expression. There is overlap in every one of those three things. It used to be they thought they were completely separate. And we now know that the fundamentals of processing speed and working memory are critical in every one of those three academic domains. But there are some very specific skill deficits that are involved in dyslexia in terms of decoding words and being able to then put the pieces together as you're reading. And in the case of math, being able to utilize working memory to keep track of what's going on in one column and getting the order of operations straight. Mm-hmm. And written expression in terms of organizing ideas and language processing. But the problem is sometimes people get diagnosed with having a learning disability and they miss the ADHD that's also there with it. Mm-hmm. And vice versa. Some people are getting an ADHD diagnosis and the people are not catching the fact that they also have a significant problem with math or with written expression or with reading that requires more specific interventions. And you can fix the ADHD all you want to with medicine and other behavioral interventions, but they also need very specific remediation in terms of teaching some basic skills related to reading, writing, or math.
Does working memory problems, executive function disorders sort of underlie? Are they the common the link between these?
Yeah,
okay.
the two elements that are most critical among the executive functions for learning disorders are all the various aspects of executive functions impinge upon learning disorders, like being able to prioritize, organize, get started, and so forth. But working memory and being able to process information at a reasonable rate of speed are the two that are most closely correlated with those problems.
Right.
Because the problem is if you can't remember what it just said at the beginning of the sentence or the beginning of the paragraph, by the time you get to the end of the paragraph, you're not going to be able to figure out what it's saying.
Yeah.
And if you have to read staccato in a way that each word is pronounced completely separately, and you're not able to smoothly move through the elements of the sentence, it's hard to keep track of. You often lose track of what the message of the sentence is.
Makes sense. Well, I'm afraid that it's 2 p.m. and we're going to have to stop. I wanted to tell everyone listening in to be sure to look for Dr. Brown's books. They really are a model of clarity, and they will make this field so clear that you will be surprised. And also to look at our new website, attitudemag.com, where we have launched a series of self-tests. These are not diagnostic tools, let me just say that up front, but they will tell you some of the common symptoms related to a variety of disorders and give you information that you can take to a clinician if you want to pursue the possibility of ADHD versus depression versus OCD versus anxiety and so forth. So in that regard, they can be helpful in helping you sort things out. Upcoming on attitudemag.com, we have on Wednesday the benefits of art therapy. I think that's an interesting topic, as well as summer screens on June 6th, how to get through the summer without having your child take over, having screen time, mass take up all the free time. And then a really interesting language processing disorder webinar on Wednesday, June 14th. So thank you all. Thank you so much, Dr. Brown, for all that you do for ADHD.
I've enjoyed it.
And it's been great. Good luck with the move. And we'll see you in California. Bye, everyone.
Take care.